Morning and a very warm welcome to all of you. Welcome to the Day 4 proceedings of the World Congress on Disaster Management. As you all know, this is the 5th World Congress on Disaster Management. Ladies and gentlemen, at the outset, may I request you all to please do remember to either switch off your cell phones or put them on silent mode. And while you're sitting in the hall, may I request you to please do follow COVID norms. Please sit on alternate seats. We would also like to share with you that there are certificates for participation for each and every delegate. So if you haven't collected yours, please make sure that you do so. So the first session today is entitled Social and Psychosocial Issues for Long-Term Recovery from Pandemics. And this session is being chaired by Dr. K. Sekar, Professor of PSW, Senior Consultant, Center for Psychosocial Support and Disaster Management, NIMHANS, Bangalore. May I request him to please join us on stage? Please put your hands together and join me in welcoming him. The speakers for this session are as follows. Dr. Hannah Fanny, she is the Technical Officer, Evidence, Research and Action on Mental and Brain Disorders. She'll be joining us from World Health Organization, Geneva, Switzerland, virtually. Dr. Nancy Miller, Faculty, School of Behavioral Sciences, California, Southern University, Consultant for Project Hope. She will also be joining us virtually. Meanwhile, we have with us Mr. Manish Mohandas, Program Officer, Resilience, United Nations Development Program. May I request him to please join us on stage? We also have Dr. Nimesh Desai, Director, Institute of Human Behavior and Allied Sciences, IBAS, Delhi. Then we have Dr. Jayakumar C., Associate Professor, NIMHANS, Bangalore. Dr. Shubhrata Prakash, IRS Director, Niti Aayog, New Delhi. Mr. Balaji Singh, Care Today, New Delhi. May I request all the esteemed speakers to please join us here on stage. A very warm welcome to you all. In keeping with the true tradition of the World Congress, this is again a hybrid session. Some of the speakers are joining us virtually and some of them are present here. So I now hand it over to the session chair, Dr. K. Sekar. It's over to you, sir. Take the session forward.
Or should I get my laptop? Yeah. Second. Yeah. Yeah. A very good morning, friends. I'm happy to be along with you, along with my fellow speakers, Fahmi, as well as Manish Mohan is being replaced by Shubham Tandon for some reasons, and Dr. Nimesh has joined us virtually. Along with that, Dr. Jayakumar and Mr. Balaji Singh, and Nancy Miller will be joining us from US virtually. And last but not the least, Shubhrata Prakash, who is the director from Niti Aayog, who is here. When we are talking about psychosocial and that of the social issues in COVID-19, we would be touching upon a bit on the past, the present, and the future, because mental health and psychosocial issues never say that the issues are over and we are closing it down. Some of the issues might be lifelong for us to be going on with the thing. So from the international perspective, Dr. Hannah Fahmi is joining us. He's the technical officer with the Mental Health and Substance Use Department and WHO Geneva, who is the one who has been heading the psychosocial support issues and mental health in terms of the disasters for the last 4 to 5 years now. And he's the one who had brought us forward in the World Health Summit, the issue of psychosocial support and DRR, especially from a flagship program of UNDP, which is carried out in 6 states and 6 cities and 5 states in the country. And following that, we have Mr. Shubham Tandon. Mr. Tandon is an enthusiastic development professional with more than 8 years of experience engaged in project management activities relating to building urban and rural resilience, environment protection through disaster risk reduction and climate change adaptations, sustainable development and enhancing institutional capacities of the government and local community as well. And when I have to talk about Fahmi, whom I said is a psychiatrist by training, has had more than 15 years of experience in mental health services and its development. He served mainly at duty stations in countries affected by complex emergencies, including at the WHO office in Syria and Libya. Knowing a flagship program on disaster risk reduction and psychosocial competencies are running in India, he visited us twice and was along with us both in Navi Mumbai as well as the other places where the program has been going on. He moved to WHO in 2014, where his main area of work includes providing technical assistance to countries on mental health during emergencies and supporting government and WHO partners in scaling up mental health care. Since July 2017, he is representing as a co-chair of the IASC group, most of us might be knowing, and the reference group for mental health and psychosocial support in emergency. Dr. Hannah is in the WHO headquarters focal point for mental health and psychosocial support and COVID-19 currently. The third speaker, a very good friend of mine, and we know each other for the last 4 decades, Dr. Desai, a psychiatrist and a qualified public health professional in public service, as well as academic career for nearly 40 years, having served on the faculty of NIMHANS in the very early years around 80s and moved to AIIMS Delhi, and currently he has been in IBAS, Delhi Institute of Human Behavior and Allied Sciences, earlier known as the Shadra Hospital, Mental Hospital, currently the Institute for Human Behavior and Allied Sciences for the last 22 years, initially as the head of the department, later as a medical superintendent, and since 2010, for the last 12 years, he had been the director. He's as the director. He has nearly 100 research papers, many research monographs, and has 5 national awards. And he works with the NGO community-based outreach program, including radio and TV. And he had been along with this in terms of drafting the national guidelines on psychosocial support and mental health services for the National Disaster Management Authority, which was released in 2009. And he is also with various other committees, advisory panels of the national agencies, like the National Human Resource Commission, Human Rights Commission, NDMA, NCW, ICMR, and others. He has worked with these agencies for mental health aspects of the pandemic, and he will be rolling out the issues pertaining to mental health issues during COVID-19. Dr. Jayakumar has about 20 years of experience in psychosocial care and disaster mental health, a colleague of mine who is there in NIMHANS for the last 7 years. Earlier to that, he was with the NDMA as a consultant on psychosocial support and mental health services. And he had been working ever since 2001 in Gujarat and later on into tsunami and all other places where there had been major disasters on community-based psychosocial support and mental health services, stress management, psychosocial well-being of vulnerable communities, policy and guidelines. He had been instrumental in the NDMA national guidelines in terms of the preparation, editorial, and getting it released. He was a former consultant in NDMA, former director technical with American Red Cross India operations, and multi-sector forced psychosocial support and mental health services is being carried out by him. Well, I'm not going to introduce anything about Dr. Balaji Singh Chauhan. He's one of a near and dear friend of mine for the last 3 decades, or let me put it as almost 4 decades. For the first decade, it was a personal friendship, but from 1999, it bloomed out to be a professional relationship. I would call him to be a Dasavatar in India, that he takes various avatars. Probably Anand Babu and Ray and everybody would be knowing, because they don't know what is avatar he is currently on. He's a subject matter expert currently and a development consultant, has an MBA. And along with the MBA, he has the richest experience in terms of working as an ordinary sort of a person of a project implementer in terms of having worked with ActionAid, Care India. You talk about any one of your international organizations or UN organizations or other US-based organizations, he is associated with every one of them, along with various other institutions back in India too. He has a field experience which no other person does have in terms of not only implementing, but also monitoring, or in terms of evaluating and taking directions and giving directions to people on subject matter expert. And he had been associated with the Times of India and things like that for a long time. And let me have the pleasure of introducing Nancy Miller, Dr. Miller, who will be talking on the psychological perspective of COVID-19 pandemic. She has over 40 years of successful leadership and management experience providing comprehensive mental health services in federal, state, private, and international settings. As a disaster health responder, Dr. Miller has been active in a variety of humanitarian crises, such as Desert Storm, Virginia Tech University shooting tragedy, Haiti's 2010 earthquake, Orlando's Pulse nightclub, and Charlottesville, Virginia domestic terrorist attacks, hurricane disasters, Katrina, Gulf Coast, Harvey, Houston, Texas, and Maria, Puerto Rico, and the refugee crisis in the southwestern Uganda and Livos and Greece. Her research interests encompass the global mental health issues in low middle income countries with a focus on disaster mental health response during and after humanitarian crisis, sexual and gender-based violence, the interrelatedness of mental illness and mass shootings, trauma responders and their recovery, the role of biochemistry and genetics in mental disorders, and military family life adjustments. As a spouse, military spouse, as she rightly says, she and her husband have had unique experiences raising their children abroad in diverse cultures. And Dr. Miller also serves as a faculty for California Southern University School of Behavior Science, presenter at state conferences, consultant of Project Hope, which might extend its tentacles back into India shortly, and a private counseling practice in Western Pennsylvania. And the last of the galaxy in terms of introducing one of a very recent stars we found is none other than Subrata Prakash, Dr. Subrata Prakash. She's a director at Niti Aayog, New Delhi, India. And she comes from a community called as Karuna community, who are proud depressives, who are a group of IAS, IPS, IRS, IFS persons who have joined together for the cause of mental health. And her own experience with depression and anxiety disorders have turned into a passionate mental health advocate. And if at all I have to say somebody is carrying the lantern forward for us, it's Subrata Prakash and her other colleague who is there in Karuna community. She has authored a book which every one of us have to look in on depression, titled The D Word, A Survivor's Guide to Depression, which was published in 2016 by the Secretary of Ministry and Health and Family Welfare. And the concern for Karuna community, both for her as well as the person who leads the team back along with her and a large number, is given the acute shortage of mental health professionals in India, They are working on strategies to suggest policy measures for the same. I'm very happy about a month back, the first level consultation with the Niti Aayog has occurred between Corona community and the other one. And I'm definite that this message will also go in the second thing by the CEO when they are reviewing at the second level with the UN, WHO and other sectors to give an impetus in terms of just not only the professionals, mental health professionals or psychosocial professionals, but the larger community organizations and civil-based society organizations can take a lead. And in that, I'm happy that they had been able to cover 7 states in a matter of about 1 month to provide psychosocial first aid. And in the interim training community resources, they have been able to administer mental health first aid required in the present situation. And based on its success, Corona community is planning to take to a much larger scale. So friends, I am presenting a galaxy of persons to you from the different fields in terms of psychosocial support and mental health services, psychiatrists, psychologists, social worker, and administrators, and that of the civil society organization responders. So let us have a feast together in terms of looking at this particular area of psychosocial support and mental health services. And I'll come towards the end to give a few remarks on the overall thing. And now let me ask Fahmi, if in case he is online, else I would request somebody from here to do the presentation for him.
Jigar, thank you so much. I'm online. I hope you can hear me. I'm really sorry for not being physically with you in India today. I would never miss a chance to travel to India and work in person with the team, but it's only the travel restrictions that we have these days. But I'm keen and looking forward for other opportunities to come and visit the wonderful team in NIMHANS. I'll start by sharing my slides now. I hope you can see my slides. Thank you. Colleagues, COVID-19 has exposed the troubling situation of community mental health services globally, even before COVID-19 started. The mental health services globally, because of decades of limited investments, were like this gentleman carrying a heavy weight and trying to go uphill. Then COVID-19 came. First, it came with direct impact of COVID-19 infections. COVID-19 infection itself have mental and neurological manifestations, from headache to loss of taste and smell, to depression, to anxiety, to delirium, to stroke. So it has its direct mental and neurological clinical manifestations. But also it comes with indirect mental health and psychosocial impact on the population, from widespread fear, hopelessness, isolation, loss of social support. For people with pre-existing mental health conditions, COVID-19 directly and indirectly can impact their symptoms, can exacerbate their symptoms. And people with severe mental disorders are known to have more severe COVID-19 infection and also more likelihood of mortality due to COVID-19. These issues, colleagues, are even worsened by the lack of access to social support system due to physical distancing measures, which is clearly affecting the well-being for the most vulnerable, such as older adults and people in institutions. Many people also are experiencing death of family members, experiencing grief and bereavement, and often do not have the opportunity to be physically present in the last moments of their loved ones. What is more, all over the world, livelihood of many people have been clearly affected, and it's well established that adversity is a risk factor for mental illness. Colleagues, it's a fact. COVID-19 pandemic is a physical and mental health emergency. When at WHO we worked with countries, we did twice a survey to map the situation of mental, neurological, and substance use services across the world from the 194 member states. We did one in 2020 and we did another one in 2022, in 2021, and there is another ongoing one that will continue until 2022. In the first survey, we found that 93% of member states responded back to us saying that there is disruption of at least one of their mental, neurological, and substance use services. When we repeated the same survey again, another remarkable finding is that we found that mental, neurological, and substance use services were the most frequent essential healthcare services among all other areas that was reported as disrupted in countries, unfortunately. Nearly 3/4 of mental health at workplace was disrupted. Mental health services for the most vulnerable, such as school mental health services, such as mental health services for older adults, were among the most disrupted. 60% of countries reported that their psychotherapy services has been impacted, and nearly half of countries have reported that substance use services has impacted. So one of the impacts is not only the direct and indirect mental health and psychosocial impact, but the disruption of essential healthcare services, because the health systems and social systems did not have the resilience to cope with such a situation. And many of the mental health care facilities were either used as a quarantine or were actually stopped functioning during certain stages of the pandemic. But there are some positive news. What we saw during the pandemic is that there was strong recognition by governments and by actors on the ground for mental health and psychosocial support, likely due to the widespread needs, but also due to advocacy efforts around the world. 89% of countries reported, that was in the two survey, that they have mental health and psychosocial support integrated as an essential component in their COVID-19 response plan. Remarkable finding here. 2/3 of the countries have activated multi-sectoral platforms for coordination of mental health and psychosocial support. But again, the survey is giving us some bad news. Limited allocation of resources. Only 17% of member states have reported full allocation of budget for implementation of the mental health and psychosocial support activities that they have included in their plan. When we repeated the survey again, we found that this only increased into 19% have full allocation of budget. The decades of neglect to this area are caused by limited allocation of human and financial resources, and likely this continued also during the COVID-19 pandemic, despite the widespread recognition of this area. The global community has made huge advocacy efforts for mental health and psychosocial support integration in the pandemic. From WHO side, the WHO Director General since April has disseminated to all regional offices and all country offices clear recommendation for inclusion of mental health and psychosocial support. All the heads of UN agencies from UNICEF, UNHCR, UNFPA, OCHA, IOM, and others have issued a joint interagency call for action for scaling up mental health and psychosocial support. The UN Secretary General has issued a policy brief on COVID-19 and need for action on mental health. That happened for the first time that the Secretary General of the UN issue such a policy brief. On response to that, 90 countries have requested from the UN General Assembly through a formal letter, I'm putting here the image of that letter, request for the UN to scale up its efforts in the area of mental health and COVID-19. All these remarkable advocacy efforts also led to inclusion of mental health for the first time in the Global Humanitarian Response Plan by OCHA, in the UN Socio-Economic Framework by UNDP, in the Strategic Preparedness and Response Plan for COVID-19 by the World Health Organization, with inclusion of mental health and psychosocial support indicators. So at policy level, huge amount of advocacy has led to integration of mental health and psychosocial support into many of the multilateral plans. And we saw that, in fact, for the first time. This is among the positive impacts of recognition of mental health within the humanitarian and UN and international NGO systems. Within the Interagency Standing Committee, which is the coordinating body for mental health and psychosocial support within the humanitarian system, we issued a wide range of resources In fact, many of these resources are either available in Hindi, translated by AIMS, NIMHANS, and others in India. In fact, one of them is actually available in 14 different local Indian languages, but all of them are available in 50 plus, some are even available in 100 plus different languages. The uptake of these resources by the international community was remarkable. Let me take you very quickly through some of these resources. We released the Basic Psychosocial Skills Guide for frontline responders. We consider this is one of the adaptation of psychological first aid, but we knew we need a different form of psychological first aid due to the different nature of this emergency, but it needs to be integrated at what is known as level 1 of the pyramid. This is basic set of skills that people at grocery store, people at law enforcement, people at food distribution services, and health worker and social care worker need to integrate into their daily work. And in fact, the Basic Psychosocial Skills Guide is available in Hindi, translated by AIMS colleagues. The children's storybook, very famous resource we developed, My Hero Is You, was developed with inputs from children around the world from 100 countries. We developed a storybook to raise the awareness on COVID-19. In fact, it is available now. It is one of the most translated United Nations resources ever. It is available in 148 different languages and 50 plus multimedia adaptations, including wide range of adaptations in accessible formats for children with disability, such as easy to read versions for children with intellectual disabilities, such as Braille, and such as sign languages in video version. Self-help guide designed based on randomized controlled trials called Doing What Matters in Times of Stress. We also developed an operational guide for agencies to integrate multi-sectorally mental health and psychosocial support. We developed the first ever resource for older adults for integrating mental health and psychosocial support into their care. Happy to share with you the link where all these resources are available in numerous languages, including Hindi and other local languages in India. Also, we activated a rapid deployment system. To date, this surveyed 32 different countries who requested deployments of mental health and psychosocial support coordinators. In fact, these two pictures are for our first two deployees who were deployed into Ethiopia and Albania, but 32 deployments went so far. These are colleagues who go to countries with limited human resource capacity to coordinate mental health and psychosocial support response, go for 3 to 6 months to build local capacity in the area of coordination, helped us in fact in increasing the number of countries in humanitarian settings with active multi-sectoral mental health and psychosocial support coordination groups. In March 2020, we had only 22 countries. And now we have 50 countries in humanitarian settings with such a coordination system, representing 90% of all countries with humanitarian emergencies. And as I mentioned earlier, in the Global Humanitarian Response Plan by UCHA, we integrated for the first time mental health and psychosocial support. It is recognized as a cross-cutting area of work. It means that it's not only relevant to health actors, but to protection actors, including child protection, gender-based violence, mine action, relevant to nutrition actors, relevant to education actors. So it is formally recognized within the Global Humanitarian Response Plan as a cross-cutting area of work relevant for all sectors and clusters. Another significant thing that happened for the first time during the COVID-19 response is that member states, in fact, it was a member state from the Southeast Asia region, it was Thailand, requested from the WHO governing body. As you know, WHO is governed by ministries of health from all around the world, and its governing body is the World Health Assembly. So Thailand put a request formally that was supported by other Southeast Asian countries to put mental health during the pandemic on the agenda of the World Health Assembly for the first time. It was a historic moment for WHO, as there was a request from a member state for the first time to put this item on the agenda of its governing bodies. So, in fact, all countries has discussed this topic across 3 days and agreed on a way forward. The way forward was to endorse the extension of a mental health action plan until the year 2030 with new set of indicators and new set of implementation options. Some of these indicators that countries will continue to report every 2 years are indicator on integration of mental health and psychosocial support into disaster preparedness. We aim to reach 80% of countries. This is what countries has said to us in the governing body, to have 80% of countries integrated mental health and psychosocial support into their disaster preparedness plan. The current baseline is really bad. The current baseline is 29%. Only around 50 countries have this integration of mental health preparedness into their plan. And we have a lot of work to do until 2030 to increase this to the target that was set by countries to 80%. Countries also set number of recommendations, such as including innovation, remote support, elimination of stigma, promotion and early detection. Happy to share with you the decision that was decided by the countries and governing bodies this year, because it's very important document that set the way forward after the pandemic as decided by the governments of the world. And most importantly, countries requested where there was a recommendation, in fact, to governments to allocate adequate funding for mental health, to increase the knowledge on mental health among all health professionals, not only mental health workers, and to study and to continue studies such as the survey we shared on the impact of COVID-19 on mental, neurological, and substance use services. The remaining recommendations are related to using the emergency as an opportunity to build back better and sustainable mental health care services. I'll stop here for the sake of time, and thank you so much for this wonderful opportunity to join you today. Thank you, Dr. Sekar.
Thank you, Hannah, for that wonderful presentation. If there are quickly one or two questions, Hannah would be there to answer the thing. Else we'll take it towards the end of it, and we can always keep communicating to him. And he had been able to put the entire thing onto the agenda for us till 2030. And as he rightly said, though 89% of the countries had agreed on the entire issue, the allocation of fund as one of a main theme for us also to go as a recommendation from here, have a better financial allotment on psychosocial support and mental health services in terms of not only the COVID-19, but on disasters generally over the period of a time. Any questions to Hannah Fahmy? Thank you so much, Hannah, for having been with us. If time permits, you can be online till the end of the thing, so that if there is some other issues coming up, we'll be there. Thank you for once again supporting.
Thank you so much. It's my pleasure.
Thank you. Yeah. May I now call upon Shubham Tandon from UNDP, who is online, to talk about the various COVID-19 issues picked up by UNDP for the entire country of India. Shubham Tandon, please.
Thank you, Dr. Sekar, and thank you for having me. Let me quickly share my screen. Is the screen visible to everyone? Great. So good morning, everyone. This is Shubham Tandon. I'm the project officer and work on the resilience sector with UNDP. Thank you for having me here, and thank you, Fahmy, for giving their entire inputs of what WHO has been doing and how COVID-19 has impacted things. Before going into the depth of psychosocial care, my session has been planned to basically talk about what kind of initiatives we have done and what we have implemented in partnership with NIMHANS this year, specifically due to COVID. Quickly running everyone through, UNDP has been around for some time, and we have been implementing various projects related to disaster management right from the start of the Maharashtra's earthquake rehabilitation program, be it the Gujarat earthquake, be it the tsunami recovery, the bigger disaster risk management program. And in the last 5-7 years, UNDP has been working specifically on urban resilience in the context of developing and providing technical support to the state. Now, India has witnessed a major change in disaster management in past 2 years, following the Odisha cyclone, the Gujarat Indian Ocean tsunami, or the very recent Chennai floods. Despite the significant stride which have been made in psychosocial support, following these disasters, there is a large gap which exists in the area of support in terms of professional infrastructure and service delivery specifically. Now, there are international guidelines. Fahmy just talked about it. NDMA has come up with guidelines on psychosocial support and mental health services in disasters specifically. But there's a need to sort of go a bit further. So UNDP, along with NIMHANS and USAID, actually initiated first of its kind capacity building program for community-based psychosocial support during preparedness and disaster risk reduction in 2017. Now, this project, enhancing the institutional and community resilience, talked about was one of its kind, where it specified the need of importance of psychosocial care during the entire disaster phase. Now, psychosocial need, we conducted a psychosocial need assessment, which was carried out with various stakeholders. We reached out to departments, NGOs, state governments. The assessment then suggested that there is a need to have a concentrated effort to integrate and build capacities on psychosocial care preparedness, disaster risk reduction, to build better coping abilities and resilience of communities. Now, towards this goal, NIMHANS actually conducted the first level TOT trainings in 6 partner cities right from 2018 and 19. Now, coming to now, where we started in 2017, during this year, we decided that there is a need to sort of take things forward and start implementing activities in context with COVID-19. So UNDP and NIMHANS started the project on psychosocial support for communities during the COVID-19 pandemic. Now, the aim was to specifically build a psychosocial capacity at the community level through UNDP and the partner NGOs at state and district level. The objective was pretty different, and pardon me, I'll be very specific to the interventions which we have talked about. So please bear with me on that. The objective was to develop a comprehensive training module to extend psychosocial support for UNDP and NGOs during the COVID-19, develop grassroots human resources capable of providing sustained psychosocial care, and to build upon and provide IEC material to the people. Now, the strategy was pretty direct. We actually implemented a similar program from 2018 to 2020. So there was a very good coherence between NIMHANS team and UNDP team. We conducted almost similar things in 6 partner cities in Shimla, Vijayawada, Cuttack earlier. So what we did was we came up with a semi-structured questionnaire, understanding what kind of needs will be assessed by the communities, what kind of assessment tool are required, and that eventually then the assessment tool was finalized. Now, based on the assessment report, the training material and the training module was prepared on psychosocial support for the communities. We developed a workbook and a facilitator manual where which was customized on the findings of the baseline assessment. Eventually, the TOTs were conducted for 9 states, where we reached out to almost around 172 people in a period of around 10 days. Yeah. So the states included, the nine states included Karnataka, Telangana, AP, Haryana, Maharashtra, Chhattisgarh, Assam, and Nagaland. Now, what was it all about? What was the TOT all about? We started with a basic pre-assessment of questionnaire where everybody shared the experience and expectations out of these TOTs. They talked about impact of COVID-19 on individuals, on families, on community, eventually specifically the vulnerable groups, how they are coping up with during COVID-19, what kind of basic counseling skills are required during COVID-19, and also prevention and promotion of mental health issues. Now, the outcomes, all these 172 people were actually gained a very good insight of what all kind of soft skills or psychosocial care skills are required during this assessment. A few of them were earlier trained as well, so they also understood the idea that how to implement these learnings with the community members. Now, web-based trainings, on one hand, actually helped to acquire a conceptual insight of the skills, but participants were still pushing for a one-to-one training eventually. We developed a lot of IEC material. I talked about COVID appropriate behavior, the myths and misconception of COVID coronavirus. There were certain issues which NIMHANS actually addressed during these TOTs. If people in India remember that during the initial phase of COVID-19, every house which had COVID, at least in NCR capital, this house is COVID affected. That steel plate of COVID affected was there in every household, most of the household per se. But once everybody in that household was sort of detected negative of COVID, that slab remained there. So it created a certain myth, it created a certain misconception that, okay, this thing is not going anywhere. It will be there because that slab was lying in the house for a very long time. So it was there. So all these challenges faced by women, specifically children, what were the impact on senior citizens, all kind of IEC material were developed. As I told earlier, we also developed workbook on psychosocial care. The pamphlets were developed. We talked about training module. We talked about psychosocial care and facilitation manual during disasters. Now, what kind of activities we did earlier in 2017, which eventually were repeated in 2019 immediately. So, sort of handholding was done for all the city administration of Shimla, Vijayawada, Visakhapatnam, Cuttack, and Navi Mumbai. And I'll just talk about what were the basic issues which all these cities were facing at that point of time. For example, Cuttack, the initial survey said that there's a lot of anxiety and fear, and there's a fear among migrants. So the city administration and NIMHANS conducted counselings and yoga session. In the case of Navi Mumbai, the migrant crisis was on a higher side specifically because there was shock due to overnight disruption. There were feeling of helplessness and a lot of confusion among people. So there were counseling sessions which were done for migrant workers in the shelter homes during the first and second phase of the lockdown. In Shillong, again, there was an extreme rise in the case of substance abuse, and the entire team started the work from medical checkups and then eventually moved down to counselings and other similar sessions. In the case of Shimla, the general issue was how to fulfill the basic needs because everything was disrupted. There was no work. So municipal corporation Shimla has addressed these issues through counselling through NIMHANS team. Now, Vijayawada, there was a fear of contracting COVID-19. So if you see in all these cities, the idea of the fear, stigma, depression, these were the few common things amidst the community people. But all these cities also came up with very interesting ideas. When Navi Mumbai talked about having psychosocial care sessions in the shelter homes, at the same time, Cuttack talked about developing a web portal and implementing and reaching out to a bigger audience through the internet. So all these things helped a lot. Talking about Cuttack, we actually trained these 40 master trainers earlier, which helped in reaching out to almost 700 people during the counseling. The webinar platform was developed, which counseled people during quarantine, reached out to them, helped them what is going on to understand what kind of stigma is to be sort of avoided during this entire phase. Reaching out in the vernacular language was also one of the most important reach for the grassroots workers. And the city administration was always there. They were always there. The municipal commissioner guided us what to do, what to achieve, and it was very helpful to take things forward. Now, in the case of Vijayawada, we started with 2 webinars. We partnered with the Nagarjuna University and AP Human Resource Department, where the idea was to talk about unlock guidelines of school, but it also covered the basic concept of psychosocial care counseling. And we reached out to almost 200 people. In COVID-19, then in Vijayawada, we talked about the do's and don'ts. We talked about ICDS guidelines. There were medical camps. And there was 17 TOTs which in turn reached out to 350 people in the line departments, which was very necessary because even during the lockdown, few of the line departments were working because they were supposed to be there in certain ways when the Department of Revenue is taking out the care of the emergency situation in the state. So the people were also stigmatized and they were fearing their life. Senior citizens, anybody earlier aged more than 55 was actually in a very bad shape of sort of reaching out to the government office itself. So a lot of things were considered by the Vijayawada administration in that case. In Shimla, there was an 8-day long program where we reached out to different stakeholders and talked about psychosocial care. We developed master trainers with various line departments and the college staff of Shimla City. Again, most of the things were web-based at that point of time. Now talking in terms of what FAMI also suggested that there's a need of finances, there's a need of transfer of administration. So in India, major challenge was that even during COVID, there was a lot of change in administration which was going on. So that was a bit difficult to handle. Along with that, when we talk about, say, the mainstreaming of this entire idea of psychosocial care, we need to understand that the number of hazards, the number of disasters are going to keep on increasing. There will be social unrest. There will be things like emergencies and elections. So we need to sort of be flexible enough and agile enough to integrate all these things within the set deadline. Now, we have to have a proper follow-up. What happened with my program as well, we did something in 2017, but eventually then in 2020 during COVID, in 2021 during COVID, we realized that we need to have a follow-up. We need to see where the master trainers are, what are they doing. So we have to do that. In conclusion, the project achieved the aims and objective which was sustained in the effort by enhancing the capacity of the people. What we believe is that a periodical training and monitoring need to be carried out to sustain this noble initiative along with integration of psychosocial care in all the training programs of the state, because it's not only about COVID. The mental health in general has come out very well, and there's a positive approach to mental health due to this COVID, if I may say, because eventually people have started talking about it in a big way. Agencies like NIMHANS and other people have been talking about it for decades now. We have senior panel members working on the sector for more than 4 decades now. But what COVID has done is it has pushed the elephant out of the box, and people have started talking about it. People have started talking about therapies and counseling in a more better way. So probably what I believe is a multi-sectoral approach, and the very idea of mainstreaming psychosocial care in the development practices should be the way forward, where we should consider that things like this might happen again, and we need to be prepared for that. So without taking much time, Dr. Shekhar, this is it for me, and I'll be more than happy to address further questions. Thank you.
Thank you, Shubham, on behalf of the organizers as well as NIMHANS for giving us the UNDP's perspective in terms of psychosocial support and mental health services across the 6 states, 6 cities and 5 states of the country, and currently more than 9 states in the country in terms of the psychosocial first aid model, and bringing out the issue in terms of need to have the multi-sectoral and mainstreaming and institutionalizing. The elephant which has started walking needs to be kept onto the running sort of a mode. And what Fahmi was saying, that it was a cross-sectional sort of a thing. Now we are talking about a multi-sectoral when it comes to India in terms of the social issues and the other things which has been. Any questions to Shubham Tandon from UNDP? Please, sir. We would be thankful if you could introduce yourself and put your question to Manish.
I'm Wing Commander Bakshi. I'm former fighter pilot and also working for ICRC for the last 25 years. My question to Mr. Tandon would be that the first thing, we have a very fine presentation, but could he tell us that with all the involvements in these fields, which you said you involved the paramilitary, you involved the state government, did the local Red Cross, was it involved in any way, or in the International Committee of Red Cross and International Federation of Cross and Crescent? Were they involved? Because they are the basic humanitarian organizations. So what was their role, and did they volunteer or did they not volunteer? And finally, is there any problem in coordinating with them, etc.? And I think even the civil defense should have a department of yours, you know, because during the trauma during the conflict, this thing takes place, the trauma takes place, a lot of depression takes place, and a lot of problem comes, the mental, psychological, everything, what you mentioned. Thank you.
Thank you, General Bakshi. For your first question, yes, Red Cross was involved, and every time we have worked in the area, Red Cross has always been a partner. As an international organization, Red Cross has this onus of taking things forward from there. And the services vary from state to state in the way they have the outreach, but they have always been very clinical and very supportive in trying to sort of implement all these activities on ground. Secondly, yes, the inclusion of a department per se, a department within a line department which talks about psychosocial care. That's what I said in my presentation, that eventually the idea should be to mainstream this very topic and start not to address it as a cross-cutting issue, but a general issue. Right? It should be a part of everywhere. I don't see if there will be a separate department, but pretty much all up for the idea that the idea of psychosocial care should be integrated within the line departments and the thinking and planning of line departments, be it risk-informed planning. The very idea of risk-informed should have a mitigation component from a psychosocial care point of view. So yeah, if I have answered your question.
Thank you, Shubham. Just to add a point to General Bakshi sir, NIMHANS had been in very active collaboration along with the Indian Red Cross, American operations. Joe Pruitt was totally involved along with us in psychosocial support, as well as the mental health services for the country, number one. In almost all the programs, NIMHANS does consider the state Red Cross societies to come into picture. Last but not the least, as you rightly pointed out, we are also working with the earlier National Institute of Social Defense back at Nagpur, giving training every 3 months in them. Dr. Saini, who was the then director, and currently it has become a NDRF training academy, and even with the NDRF training academy, we are continuing. But with Saini and others, we have now got into the fire force, where we are heading into at the national level sort of a issue. And apart from this, you spoke about the army. NIMHANS has started working along with both two novel projects, one for the entire Tamil Nadu police, 1,25,000 personnel, and their family members of 3,75,000, totally putting about 5 lakh per population. We have taken them onto a wellness program because they are one of the stressed lot when they come under uniform services. Following that, the ITBP, Indo-Tibetan Border Police, has also taken up. So that probably answers your questions, Dakshita. Thank you. There's one more. Shubham, there's one more for you.
Yeah, I am around. No issues.
Hi, Shubham. This is Colonel Srivastava.
Oh, hello, Colonel.
We are seeing the vulnerables and exposed people who are from the deprived section of society. They are suffering most, and their mental health care is a matter of concern. They are the most affected. They are the most suffered. We need specific point of interventions for these communities. You know, talking various intervention points at the departmental level and all is fine. But what is the mechanism we are following for taking it right up to the last mile? If you can elaborate on this.
Yeah. So Colonel Srivastava, thank you. Brilliant question. So the very idea when we started this project in 2017, not talking about the COVID project, but talking about the enhancing community resilience. The idea in partnership with NIMHANS was to come up with master trainers at the community level. So I think the very idea and reach of people at the community level can only happen when we have people amidst the community talking about this section, right? So during the earlier intervention of 2017 to 2019, we actually developed almost 350 master trainers, if I may say so, with different TOTs at the community level. These were not the people from line department. These were the people who were working with Anganwadis. These are the people who are working with primary health centers. These are the people who are working with local NGOs and implementing activities on ground. And they were the part where they took it forward through FGDs at the ground level. They took it forward during panchayats at the ground level. So I think this is one of the solution which comes to my mind immediately. Making sure that the community itself, when we have been talking about community-based disaster risk reduction for almost 2 decades now, the idea now should be probably talking about psychosocial care along with community-based disaster reduction at the community level. That should be the way forward, I suppose. Yeah, Dr. Shekhar?
Colonel Srivastava, sir, thank you for your question. If I could add up along with Manish, what are the things at the other national front and things like that, what I would like to put you is a thing. First and foremost, as you rightly pointed out, the deprived society is having a large amount of a mental health issue. Poverty and mental health issue has been one of the Lancet publication which came up last year. And it has stirred up the entire world in terms of showing how poverty is associated with mental illnesses and other issues and all. So the very basic premise of it is not only from your point of view, but a well-researched and documented, evidence-based sort of a thing which brings out that, number one. But what are we doing towards it is the question, what you're asking. Apart from what Manish said, to add up, is that the line ministry, the health ministry has taken it up from 2018 onwards. In almost all the states of the country, except for 2 of the state and 1 union territory, we have covered master trainers every state-wise to take mental health down to the lane in terms of the last mile connectivity. number one. After doing for all the 4 regions and the center region, these number of TOTs among the health group, we are now started working and we have completed 2 states with about 3 persons per district to be a master trainer, so that they percolate the further training to a large number of our health cadre personnel at the taluk level, village level, and the hamlet level. Because agency cannot be reaching down to the core sort of a thing. But as Manish pointed out, various tools and techniques, what has been done here, the message goes down to the grassroots level sort of a thing. And that is where the connectivity between the line ministry as well as the organizations like UNDP, which is on a developmental perspective, we combine not only the health sector, but women and child, we combine that of the social justice, we also combine the revenue, we also combine it along with the education and other things, so that a larger developmental perspective is sewed in or plowed in, and that's what we call it as a spectrum of services to come into the thing. And that is one of the fight of all the panel members who are here, who had been working for the last 2 to 3 decades on the issue, to stabilize it as an intersectoral approach rather than making it purely a health sort of a thing. I don't want to talk only about mental illness. When you're talking about mental illness, when poverty is associated, developmental indicators also need to be shown into the picture. And that is a larger thing. And now the government of India has invested, saying that 3,880 persons will be trained within 2025. And we have covered only 200. I'm sorry about it, but we started it very recently, about 2 months back, and we have covered. We'll be on a mission mode onto it. Thank you. If there's, thank you, Shubham, for your wonderful presentation and giving us the national perspective in terms of what the UNDP as a developmental partner for us have been supporting onto the issue on the COVID-19. Now, could I go to Dr. Nimesh G. Desai, the current director of IBAS, he is online already, who will be talking about the mental health issues in COVID-19. And he has been doing a lot amount of and a great amount of work, especially on the migratory workers and the vulnerable populations, what Colonel Srivastava was talking about very recently. Over to Dr. Nimesh. Thank you, Nimesh, for being along with us, though virtually. I know the problem of the diesel vehicles and others not permitting you to Delhi.
Thanks, Shekhar. Thanks very much. Good morning to all of you, and thanks to Dr. Dhar Chakraborty, Shekhar, my friend, and the organizers for having me here. I feel privileged and encouraged by the 2 presentations that Hannah and Shubham have made, because I think that's going to set the stage for what I want to say, and I'm sure the other speakers will complement that even further. From an overlapping but slightly different perspective, as these 2 colleagues from international agencies shared, I'm going to talk about what I have learned in last few years, and specifically last 2 years. I hope you can see that. I'm going to talk about what I have learned over the last few years, and especially last couple of years during this pandemic, at the ground level, in the hospital, on the street, at policy making bodies in the country, and from friends that we have, like Shekhar said, such a galaxy of colleagues here. First of all, that's the institution that I'm at. That, I must say, actually sadly describes the situation, the global universal situation, but in a lighter mode, with all apologies to Hannah. That's the set of guidelines that Shubham and Shekhar were referring to, that the NDMA developed and released in 2009. And I'm referring to that because there are a couple of things that I'm going to call out from there. Some of the few things that I think Shekhar and other colleagues, really representative national group worked out in that guideline was, and I think that was useful in this period of last 2 years to an extent. Not to overdiagnose psychiatric disorders or diagnose too early, not to medicate unduly or too early, but also at the same time, not to miss out or overlook the needs of old and new mental health cases, so to say, and the needs of their families. And so that I have realized from at least 2001, if not earlier, the previous century itself, and Shekhar and we have all learned this together, that at the program level, at the ground level, That's the delicate balance to strike, and I'm sure all of us have seen that in different ways. What are the major findings, as I see, for this epidemic in terms of mental health and psychosocial support? Surely there has been universal distress. There have been short-term stress disorders. There is recurrence and relapse of persons with mental illness. Long-term psychiatric disorders, I still say, is less than feared or apprehended, fortunately. There's a huge cross-cultural variation in the frequency and the manner of presentation of PTSD as well as their outcome. And most importantly, the informal, semi-formal community mechanisms of support actually are very useful. And so programs like what Shubha was describing do so well and will continue to do, I think, even better in terms of only complementing and strengthening the local community mechanisms than bringing in foreign science, so to say. For this epidemic, what have been the common trends and impressions in 2020, at least the first few months or throughout the year? A lot of apprehension about there being a psychiatry or mental health epidemic, that mental health services will prove to be inadequate, that mental hospitals, mental health institutions, and psychiatric wards are more susceptible and likely danger zones. And that, I dare say, I hope Anna will agree, has not proven to be so. That was such a judgmental position-based view from some quarters. And yet, one must say, there was apprehension, and not entirely unfounded, about neglect and oversight of mental health issues, especially what Colonel Srivastava, I think, was referring to, people with severe mental illness and in the underprivileged populations. Have they really been attended to well enough? And of course, the direct stigma of persons with mental illness is continuing even during the epidemic. And I think we need to recognize that. To recap to such an august body, the psychological and psychiatric consequences, as we all know, would be initially it was lockdown and the isolation. In the second wave, and especially after that, was the fear and apprehension of infection. And of course, now and in the next few months and years, there's going to be huge psychological and psychiatric and mental health impact of the economic slowdown. In 2020, almost everybody was feeling worried. And I'm sorry for that. It meant was feeling worried. Whereas in 2021, after the second wave, there is virtually nobody, at least in this country, possibly on the globe, who hasn't had some direct or indirect trauma. ICU experience, having been on ventilation, a family member or a close friend in the ICU, of course, people who we lost, and the experience of losing and the issues related to that. But I do want to highlight this. My educated understanding from last few years and the data is that there is the real and the apparent psychiatric epidemic. The possible contributors to perceived epidemic of psychiatric disorders are these. One, there is a huge amount of recurrence and relapse of people who were on treatment across the spectrum. Two, there were cases in the treatment gap that got identified and came forth. And I don't need to highlight to this august body that globally, the treatment gap for neuropsychiatric or mental health disorders is anywhere between 50 to 60% or 80. And in India, it ranges to be really 80 or 85. Three, acute stress disorders or transient self-limiting disorders of anxiety spectrum that get well by itself. And subsyndromal mental health problems, or what we might call as significant psychological distress not amounting to psychiatric disorder. Very briefly, let me recap, having been in Delhi and, like Shekhar said, having involved in some of the activities at the level of the state and the nation. What happened was this: there was a tremendous effort, and yet not completely successful, in continuation of mental health services that ought to have been and continues to be priority number one. Of course, the innovation of telemedicine, telepsychiatry, telemental health services, which was huge benefit. With the legal framework coming up in this country, all the better, and a few other countries. Spread of counseling services, all types of counseling services from academic institutions, from NGOs, from professional bodies, and whoever was around. Formal programs on psychosocial support that Shekhar and I were part of to an extent. Important aspect that we need to focus on in this session: care for the carers. Care for the carers who are not only first responders in generic terms, but especially mental health workers, professionals, paraprofessionals, and mixed role of the mass media, I would say largely positive. The trouble came when you talk about social media. The influence of social media on the psychological well-being was very mixed, questionable, and possibly not very helpful. And that's something that we need to weave into our programs for psychosocial care, it seems. What are, as we near the end of 2021, what are the mental health concerns for 2022? Firstly, of course, the third wave, and I hope in a lighter vein again, I hope nobody has traveled, Shekhar, to this conference, this Congress physically from Belgium or South Africa, because today and in last 24 or 48 hours, the concerns are becoming very different for new variants. And so much as you would like to believe that the epidemic is over, like they say in cricket, it's not over till the last ball is bowled. So that's one concern. Two, obviously huge possibility of depression, suicide risk associated with that. As Ahmed said so beautifully in his first few moments, the neuropsychiatric and the behavioral and the psychological mental health issues of long COVID, post-COVID syndrome. Will there really be increase in prevalence of psychiatric disorders? Or as I said earlier, is that going to be mostly an apparent pandemic for major mental disorders? For sure, the softer problems of mental health, as I would call it, is a huge concern universally. And that's where you need more of psychosocial support programs than really clinical psychiatry alone. For sure, clinical psychiatry and clinical mental health will have to form the bedrock, but the framework and the program implementation will have to be, as has already been highlighted, really on a larger framework. Having said that, I do also believe from data, social science, disaster mental health, and everything else, that the capacity for human adaptation is actually limitless, not only for a few gifted individuals, but actually for a large part of the human race. And that came through, to my mind, that came through in this epidemic. Obviously varies across cultures, subcultures, individuals. South Asian and other traditional societies have had the benefit of larger ability for human adaptation. There is good enough data for that. The individual resilience, the family support, and the socio-cultural coping mechanisms being very different across cultures, and some of the South Asian or Afro-Asian countries having advantages there. How far do we in our programs really weave this in? And as I said earlier, do we try and complement through our training what's already there in the society, or do we try and replace with what we think we know? To me, that's a very important question. And of course, there is this issue of whether mental health morbidity, their course and outcome in disaster situations is similar or different based on the mechanisms that we spoke about. Most importantly, the underlying theme. And I think the global community needs to start recognizing, especially in mental health and psychosocial care context, the importance of collectivism versus individualism that different cultures carry. The issues, soft issues, and Shekhar and we have discussed this sometimes in the epidemic period. Do we see this? Fortunately, the global community has seen this as an epidemic mostly, except for very small pockets where people tried putting it as a CBR and disaster because it has too many other implications. Was enough done for people with severe mental disorders, especially from the marginalized populations? And I really have a bit of a dismay there, because like some of the colleagues raised the question also, and I work with the homeless population, as Shekhar said, with migrant population and the people on the street, not just from the hospital, but of my own interest with the NGOs. And there seems to be having a little less emphasis on, I would go as far as to say that while it's great that the mental health issues have come center stage, mostly it has been about those of us who live in organized societies across strata, and two, about issues of depression and anxiety and the softer mental health problems. The large populations that actually suffer from severe mental disorders, especially in the lower strata, and the invisible marginalized populations, I think still deserves a little more attention from us in the next couple of years. And to that extent, I raise the question, have we learned enough for core mental health planning, for psychosocial care, and as colleagues have been saying, how do you integrate and mainstream mental health and psychosocial care to all development programs? At the same time, to me, it seems that in psychological sense and in psychosocial sense, the policy spin-offs have been, there is increasing trust in science. There is the emphasis and recognition of health issues, even in pockets there where there wasn't. There is enhanced discourse on mental health for sure. There is the value recognized of interdependence at all levels, be it geopolitics across countries, be it across agencies, be it across organizations, be it across cultural subgroups, or individual to individual. So to me, one of the huge lessons for human race, and that's very applicable to the program that we should follow in next few years, is highlight the issue of interdependence and acceptance of the scientific reality, acceptance of the clinical reality, acceptance of the public policy reality while working towards betterment. And so what the way forward? To me, it would seem, and I put this to all the esteemed colleagues on the panel here and Shekhar for us to see if they want to come up with a summary statement. Consolidate mental health services first. First, let's strengthen and consolidate what we are already doing. Make sure at every level we protect interests of welfare and welfare of PMIs, especially as we said, people with severe mental disorders in marginalized populations. Still much more active advocacy required for government policies during such epidemics or disasters to be a lot more sensitive to the neglected sections of mental health. And of course, the interest that society seems to have now had in mental health, even more than earlier, as colleagues said, be channelized really for effective policy decisions for long-term effect, as Shekhar keeps highlighting. And so in summary, there is surely very high level of interest in the society and some awareness about mental health issues. Will that sustain meaningfully? In the official policies, in the heat of the epidemic, I think there was still lower emphasis on people with mental illness, and I think we need to improve that for future. There have, of course, been the ambivalence and the mixed response pattern of the society, including policy-making bodies, I dare say, do continue. It's not totally gone away. And so a lot of people, like all of us on the panel, including people like Shubhita Prakash and our young colleagues, I think is required much more now than it was earlier ever. I would only say towards the end that whether all this will happen or not depends on all of us collectively. As we are very fond of saying, mental health is an issue for all of us, and there is no us and them. We'll have to not just carry people across different sectors, but people across the strata of society with us. I will stop there, and you have the email IDs and the phone numbers for social media messages if you would like, any one of you. Thank you so much once again, Shekhar and the organizers.
The mobile number so that people would be able to get back to you on some of the interesting issues on the psychiatric epidemic. In fact, I also went on to the newspaper that India needs a mental health vaccine rather than the other vaccines as of now. And the collectivism as well as the individual resilience, what we need to develop, and advocacy, that's the reason we have brought in now Shubhita Prakash here, so that she takes on to the advocacy onto the policy front to a larger extent. Thank you. We'll be in touch along with you over the question. Because of the time shortness, may I now call upon the other partners to come in terms of the presentation. Dr. Jayakumar to talk about the social aspects of the pandemic COVID-19. Dr. Jayakumar. Jayakumar would be cutting it out to 5 minutes to compensate the time.
Thank you, sir. Without wasting my time, I think I need to run a 100-meter sprint. Thank you, Chairperson, my co-panelist, ladies and gentlemen. Yeah, today we are talking and seeing so many things about the COVID-19, and many of us may be aware or may not be aware of what is happening at present at the PMO office. Is there is a meeting on Omicron. The Omicron is the new variant of virus, which is there fast spreading in South Africa, and there are actually scenario is changing very rapidly. So this is what, it is not yet over, like the previous speakers talking about. My topic here is that on the social perspective. So it is just not actually any psychosocial is just not about the biology, just not about the psychology or cognitive or the thoughts or the behaviors. It is also a large number of issues which is emanating from the environment, experience, and economy and the social situation. So we are living in an age of COVIDization in last 20 months. And there hasn't been anybody here who is not touched directly or indirectly in this COVID-19. So without actually going much into it, all of us or some form had the impact of, psychosocial impact of COVID in our lives, in our families, in our dear and near ones, and larger at the society level. So the social aspect is definitely actually takes a hit, and it comes on our well-being. Disaster always actually comes with a distress. Stress actually goes into a distress, and distress actually goes into a dysfunction, and dysfunction actually goes into a disorder, and disorder late goes into disability, just to sum it up. So this is where actually that we need to actually look into the social determinants, and the popular social gradient theory also says that it is just not the impoverished or the less privileged who tend to have more vulnerable to the mental health issues. In COVID-19, it has changed. It brought into a great equality, whether you have or you don't have, everybody suffered on this. So to quickly put into it, and of course, like Colonel Srivastav said, the marginalized groups are the most vulnerable. Among the vulnerables, the whole population also. So some of the impact which we come across seen in COVID-19 is, these are all some of the things: social distancing, stigma, self-isolation, all these things. I'm not having a time. The social impact of pandemic is enormous. There is actually, you can actually name it, you have it or experience it or witnessed it. My point here is that it is just not actually on the psychological front or a biological front. And today, the evidence says that the prolonged exposure to stress changes the structure of your brain. The recent fMRI studies also points to this. So whether you live in an unprivileged place or you are surrounded by the environment which is not conducive, definitely actually it is going to have an impact on your health and mental health. And definitely, so your well-being is moving towards an ill-being because of all these things actually contributing on your social impact side. So added to that, the mental health in this last 20 months seen in different phases of COVID brought in all these sort of issues which directly or indirectly has a sort of a social imprint and definitely go into the relevance on the well-being of the person. So you can see the slides. So there are a number of studies and surveys went on, and overall the quality of life of the community has been affected right from the individualistic point of view to the family and to the community. So the vulnerable populations, it is just not the vulnerable populations. Among the vulnerable populations, there are many minority are there. So they were actually all left out. So here actually that three important aspects were left out in this mental health provision or a psychosocial provision is that the accessibility, the availability, and the affordability. The three A's actually were missing under normal circumstances. In India, the resource crunch is very far and wide when it comes to mental health, and the disparity of reaching, the disparity of accessing these services again actually went into a very challenging sort of a task during this COVID-19. So this is what we run the national helpline, which so far catered to around 6 lakh population on a telemode, which is going on in 13 Indian languages. And whatever the issues we identified, even in that online sort of a format, 2020 and 2021 differentially brought us actually these sort of a very commonly seen psychosocial issues. And I hope, I don't want to add one more column in 2022, but I don't know actually that today in last 24 hours, something is happening, something and drastically. So the long-term, the short-term implications of psychosocial is enormous. The WHO has been warning right from the beginning that there is going to be an amplification of mental health issues roughly from 3 to 5 years on the coming down the line, affecting every segment of the society. And these are the some of the causal and protective factors affecting mental health. I'm not just talking about the weakness of the community, of the individuals. There is also actually a lot of strengths among the communities, the resilience aspect of the communities. So we need to cap that and we need to tap that when you are providing psychosocial care. And that is what actually been advocated all over the psychosocial care interventions. So to build back better, Hannah was talking about it. So are we actually in that mode? Yes, of course. He was talking about 89% of the countries have integrated this component as one of the multi-sectoral component. But the same WHO also says that 93% of the countries actually that struggled actually to provide this sort of a care cutting across the population, because COVID is not a one-time sort of a disaster. It is the level is a global sort of a level. So we need to actually look into this aspect on the latest stage actually when we how to deal with this community. And even the Sendai framework talks about only the structural and environmental aspect of disaster risk reduction, but they are not actually talking about emotional aspects of risk reduction. That is exactly actually that we have been pilot tested in some of the places which was shared, and that is going to be rolled out to entire country through various systems. And of course, we have certain trends actually been changing during this last 20 months. And these are all some of the things actually gone from the very traditional sort of an intervention to sort of an untraditional sort of a thing where from tele to reaching out to the community to home-based sort of a things actually we have been focusing on it. So my point here is that pandemic is already there, and it will be there for some time, and we don't know when is this third or fourth, God forbid. But the thing is that each one is impact is interlinked, and we need to actually have this social perspective providing the psychosocial support. So let us not actually look at any psychosocial care interventions, services, or research or capacity building unilaterally from psychological point of view. Let us actually think from holistic point of view. So with this actually that, thank you, sir. I could actually sprint as much as I possible in this colder Delhi. Thank you very much for your patience listening.
Thank you, Dr. Jayakumar, for bringing in the disparity, the pandemic exacerbation, which has brought in the inequity and asking us to be interconnected at this particular time, rather than maintaining the social distance on the type of modes of it and all. At this time, I'll call Dr. Balaji Singh to talk about the civil society responses in terms of the COVID-19 pandemic.
Yeah, good morning, everybody, and thank you very much, Dr. Shekhar. And in view of the paucity of time, I'll be using some of these slides a little more creatively and speak about how to look forward rather than what has happened. You know, why are NGOs important? Why do we need to talk about NGOs when we are talking about the psychosocial care? You know, a couple of reasons why we need to talk about NGOs is they're one of the, initial converts. I remember that, right from the beginning, and that the NGOs had been taken this subject matter very seriously, and the roles NGOs played were different. They were not only the last mile in terms of the service delivery. They were the ones who have represented well the most marginalized. And also there were a lot of times the supporters, the funders of the ideas, in terms of creating tools. So NGOs had played a very creative and different types of roles. And that's one of the reasons I think, and I'm sure I'm not wrong when I'm saying, if we have seen the evolution of psychosocial care to the current level, and NGOs had played a very critical role in bringing it to this level. And that's one of the reasons why we need to talk about NGOs. Another reason why we need to talk about the NGOs is that, the best of the services, if it is left undelivered, it is useless. And when it comes to the service delivery of the psychosocial care at the disaster during the disaster response, once again, NGOs were in the forefront providing those services. Either it is training, either it's counseling, or managing the entitlements of the most marginalized communities, which has come out. I think they were in the forefront in partnership with the administration, in partnership with the scientific community from NIMHANS and the other organizations. So they played a very key role in the service delivery. I think these are the two reasons why I feel that we need to talk about the NGOs when it comes to a very, critical subject like psychosocial care. I don't need to talk much about it. The previous speakers have spoken a lot in terms of what had been the impact of the pandemic. And we also spoke about a lot in terms of who are at risk. And the time and again, we spoke about the most marginalized and also people like aged and children and women and others. And we also spoke in terms of the psychosocial, a bit in terms of the psychosocial care paradigm, which NGOs tend to, sort of pursue. We have spoken about that. I think they talk about the normalization approach, the reactions during the abnormal situations being normal. That is the understanding which the NGOs have, and they look at the normalization of approach and activities. Again, the NGOs have done multifarious activities as a part of this COVID response. But what stands out, what stands out the way the NGOs work is a couple of things are put in the boxes. Their willingness to work in challenging situations and take risk. During the COVID, I have gone to a lot of, relief operations and all that, where there were distribution. And I have not spoken to any NGO volunteer who were either afraid or unwilling to come or needed special provisions to come for that particular field assignment. I think that is something which I thought was very outstanding when it comes to the way they have delivered their work. And also a lot of them felt that it is like the call of their duty, just like the soldier feels on the border. I mean, the NGO volunteers, NGO workers felt that it is their call of the duty. I think those are the two things which sort of, puts them a little apart from others. And that's one of the reasons probably, they are very well suited to do the kind of activities which are required to be done in psychosocial care. And also psychosocial care, some of the activities which have been taken up during the pandemic, these are the ones. And they have been creative enough, setting up helplines to help people, and the telemedicine, telecounseling by the NGOs. I think they were one of those very few people who are willing to adapt, who are willing to innovate. And that's one of the reasons, again, when it comes to the psychosocial care, the NGOs are important because they are willing to adapt, they are flexible. And so that's what I try to, capture as why are they uniquely positioned to play this, great role if we have to realize the objectives of the psychosocial care, mental health. They're very uniquely positioned because they understand the integrated approach. They understand the approach of providing relief and then providing counseling or psychosocial care services. So they understand the integrated approach very well. And they have also very good spread. Whether we are talking of the villages or, wherever you go, you'll find some NGOs who are willing to be that last mile connectivity. And they're highly flexible. Yeah, flexible in terms of moving from one place to another place, moving from relief to rehab to recovery to, and then adapt what is required to be done. So that's one of the reasons they are very uniquely placed, and they become choices of, service delivery. Yeah, learnings, I don't think we need to elaborate much on that. NGO volunteers and the civil society act as a critical need of a person, determines the service, and psychosocial care training helps in identifying the needs. And I think I just want to spend a minute on the recommendations. I feel knowing that the NGOs play a very critical role and looking into the future, which has been highlighted in terms of what might happen in 2022, and also the protracted nature of pandemic, I think there is a need for the NGOs to keep focusing on the work what they're doing, and they need to dig deeper, and they also need to spread wider and continue the good work what they had been doing right now. And also to expand and broad-based activities by involving more volunteers, students, youth, and also volunteer force like Abda Mitras. So there's definitely a scope for expanding NGO activities. And also in the future, I think NGOs need to very proactively reach to COVID-affected persons and their families and try to design services for them. And also, I think that one of the aspects which NGOs could focus on is to provide integrated database of people who are trained and share this with as many stakeholders as possible, including the administration, so that they can be very effectively and purposefully deployed. And also, I feel that they could explore connecting trained volunteers to, how do we bring from psychosocial care and use that great force which is available on the ground to detect even mental health issues. I think we need to make the transition, and we need to do it, and NGOs need to start thinking about it in the future to come during the pandemic. And also, I think my request to the government is provide greater recognition to the role of the NGOs in the mental health and psychosocial care, and provide financial support for these, and also connect them and integrate them with the administrative system on the ground, whether it is health department, revenue department, so that they can all work integrated manner to reach out to the needs of the population, especially the most vulnerable population. Thank you.
Thank you, Balaji, for the thing of asking it to look, listen, and link in terms of the impact risk. The first time I'm hearing the hazard risk vulnerability, what needs to be brought up when we are talking about the CSO sector. And as a HRV analysis, also giving us the antidote as a psychosocial paradigm of normalization to be bringing in. The larger thing which impacts us here is the emotional empathy, or empathy with the emotional drive, and a positive deviation for the outreach which comes in, and a greater recognition and a financial support. And we definitely will make it to have an integrated database when we are talking about the very trainers. Thank you. Now, Nancy had been waiting along with us for the last 60 minutes to 65 minutes. May I call Dr. Nancy Miller back from US? Thanks for having an extra long day on a Friday evening. Nancy, to you, to talk about a particular hope, what you are going to bring into the community.
Good morning, and thank you for this opportunity. On behalf of Project Hope, I wanted to share. Project Hope started in 1958, and it began as the SS Hope ship. It was the world's first peacetime hospital ship. And Project Hope is a renowned global health and humanitarian relief organization. We empower healthcare workers facing the world's greatest health crises to build resilient communities and healthier, more equitable world. My presentation today is focusing on the mental health and resilience for healthcare workers. I am a mental health and resilient expert, subject expert consultant for Project Hope. And I will, in the second half of my presentation, present a project that we're working on globally. I'd like to right now take a moment and invite you to relax, since you've been in the conference for days, and give you the opportunity to clear your mind and just calm down for yourself. I think that's important. I'll often say to my clients and coworkers who I'm working with, if we were able to have a prescription that has no side effects, that we can take anywhere with us, that doesn't cost anything, it would be deep breathing. It clears our minds, help us relax, takes the stress out of us, and help us focus on the moment. And what we have found with the pandemic now, almost 2 years, the amount of stress that has been on our healthcare workers. They've been affected cognitively, emotionally, behaviorally, physically, and spiritually. The global pandemic has been a universal experience for all our front health line workers. They've had the surge in care for the demands of so many people that they've been dealing with. They've had to risk infection for themselves, as well as dealing with patients and clients that have been infected with the COVID-19. We've had equipment challenges, shortages, ventilators, PPE equipment. Not only were they providing medical care, they were also providing psychological care and support. This continuum, the color continuum here, you're familiar with how it shows how stress is a continuum, and the green is the more adaptive coping. People are functioning in a positive well-being. Yellow signifies slight distress, mild, transient, maybe some behavior change and irritability. And then as the stress increases and becomes more severe, that tends to be the impairment, as you would see in the orange color. And lastly, red signifies where the stress has caused damage and injury and diagnosable illnesses such as PTSD, depression, or addictive disorders. This demonstrates the changes that we have when we're dealing with disasters. There's always those individuals that can bounce right back and have that strong resilience. And then we have some that, more minority that will have behavioral and emotional stressors. So for example, changes in sleep patterns, or being irritable, but then, or like substance abuse use and their behaviors, But then there's a small minority that will develop the diagnosis such as the PTSD, depression. So trauma, as we know, is individual for every person. So we may have some workers who can bounce right back and other workers who kind of get stuck from the trauma that they've been dealing with. What we do know is that it's a disturbing event that overwhelms the individual's ability to cope. And there's a feeling of helplessness and hopelessness. It can diminish one's self-esteem. And if their well-being in life has been in danger for a long period, it creates this additional stress for them. We have collective trauma and then individual trauma. And what we know is that the resilience individuals have helps them to bounce back from adversities. But what's important to realize is the education that would benefit the healthcare workers for them to receive the support, and also the collaboration between psychiatry and other disciplines in disaster management is essential. What research does show is that the workers who are witnessing and experiencing the fear, the horror, and the helplessness of their clients or patients takes a toll on their psychological effects. Down here at the bottom, the lower right screen demonstrates traits that help protect and build resilience, such as spirituality, social support, being optimistic, and adapting. Trauma reactions that are experienced by healthcare workers is caused because of the occupational duties that they have, that they develop these symptoms because of witnessing what their patients and clients have gone through over time and time again. So for example, overengagement could be an example of when you might have seen a healthcare worker is so involved with one patient that when it's time to change shifts, they don't really want to hand that patient over to the new staff. They're so involved with that patient. Compassion fatigue, I simply compare that to just caring too much. So the healthcare worker's very fatigued by caring. Burnout is a depletion of energy. And then secondary traumatic stress and vicarious trauma are often confused, but also used interchangeably. Some commonalities is that they are indirect, but the difference is the secondary traumatic stress is one incident that they have, through secondhand, have heard of the trauma or traumas, but it's one incident. Vicarious trauma is multiple exposure incidences, indirect. And, but the symptoms are similar to post-traumatic stress disorder. Why is it that healthcare workers, and you and I, and those in the audience, why are we the most resistant to receiving help for ourselves? It's difficult for us. There's a stigma, there's a self-perception stigma, but there's also societal stigma to receiving mental health care. Often as workers, we feel like we should be self-sufficient, or we'll say we don't have time, we don't have the money, or I should be able to take care of myself. And often there's that barrier and resistance for healthcare workers to seek help when they need to. There's evidence-based tips on self-care and coping strategies that help others as well as healthcare workers. What we do really encourage is during crises, during deployments, during the stress that we've been under managing the pandemic, is to minimize such substances such as drug and alcohol and over-the-counter type medications. And what's promoted is exercise, getting plenty of sleep, eating well, working with your colleagues, mindfulness, relaxations, moments for yourself, and even humor. I think humor, we know, lifts our chemicals in our brain as antidepressants would, and to encourage that with our staff to help during these trying times and family. So lastly, I'd like to encourage that your staff is your greatest asset and your strength. And it's so important to manage our healthcare workers so that we prevent the burnout, the staff turnover, dissatisfaction with work. And the way we encourage that is to develop this trust and empathy within your staff, and so that you're able to refer and give them resources if they were to need it or come to you. And we also recommend always to follow up with an individual who's been entrusted to you and shared that they were struggling. I'd like to take a moment now to briefly share with you our project that we've been working on. It's a global implementation for 2021 and 2022. And we have coordinated with New York Health and Hospitals, who've provided the curriculum for us, which has now been adapted, and the materials are adapted and translated to many, many countries. And this slide shows the countries where the implementation of the program is being held and to be held. Currently, we're in Latin America and Caribbean, and Indonesia, Southeast Asia. We're also going to be working in Africa, Southeast Europe, India. So you can see the world maps where the program is being implemented. It's a train-the-trainer program, and we've adapted the materials and the curriculum in multiple languages. Our goal is to reach 30 countries and 50,000 healthcare workers. These are local authorities and institutions that are advocating for the mental health and well-being of healthcare workers. So you can see many international partners that we've partnered with globally. It's a 5-module curriculum reviewing stress and trauma with the healthcare workers, personal professional wellness, impacts on them as frontline workers, ways to seek help for themselves and their teammates, and then developing their resilience and wellness, and perhaps for their organization as well. We have positive testimonies from those that have already completed the TOT training. And I'll just share one with you, a physician from Dominican Republic. And they quote, "For me, this has been more than just a professional training. My life and that of my family has benefited by the opportunity I had to attend this program. This session helped identify that a family member is facing some symptoms of mental health issues, and thanks to the information I received here, I was encouraged to help her in time. I am infinitely grateful. A physician from Dominican Republic. Lastly, our project involves research, ongoing evaluations with our TOT healthcare workers, from pre-test, post-test to evaluation. But we are also doing a 1 month, 3 month follow-up in their own change of their lifestyle and to see if the training has impacted their own self-care. So I thank you for this opportunity, and I appreciate it. If you have any questions. And I thank you very much.
Nancy.
Oh, you're welcome. See, I really want to, next year, I really would like to be in person.
The individual and the collective trauma and the way for the resilience forward. The secondary, the vicarious and the compassionate, compassion issues and the fatigue and the burnout, what the healthcare workers and the institutions need to take care, and for bringing us the trust and the empathy and referral and follow-up at a larger front. And we look forward that some point of a time there'll be a ray of hope back in India too in the coming months of the thing. We'll wait for some of the questions and answers as I call upon the last speaker for the day. That is going to be Subhadra Prakash, who is from the Niti Aayog director, to take up something on to the policy front and that of the larger advocacy. And I need to thank at this point of a time Ms. Archana Verma, who is one of the team leaders for the entire work back in Corona community. Ma'am, please.
Thank you, Dr. Shekhar, and a very good morning. It's almost afternoon to everyone here. So without much ado, I'll just start with the slides. I'm just trying to... Slides, please.
Shubhra. Okay, and this is the keys to.
Thank you. So I'll just briefly go over the first couple of slides because already a lot has been spoken about on these areas. First is the assertion that COVID has had severe impact on mental health. And we are all aware in our surroundings of several anecdotal accounts of increase in cases of anxiety, depression, and grief. And the impact of COVID also has been particularly felt by the frontline workers. So even when there was no COVID, the figures for the resources that we have and the burden, so as to say, although as someone with lived expression, I don't like the term burden, but for want of a better words, I'm just using something that's common terminology. So we, there is obviously a very strong need to bridge this gap in care that we have. And it is towards that end that from the policy perspective, we started looking at who are the various stakeholders when it comes to mental health care. So as you see here, obviously at the center of the entire framework and infrastructure of mental health care is the beneficiary, the person who's actually going to benefit from the policy or the intervention that is being looked at. Then the community at large, because this person is ultimately a part of that larger community. The state governments, because ultimately all the health policies, most of them, and the health subject itself is a state subject, and the state governments have a very, very large role to play when it comes to any kind of healthcare. Then also the formal mental health care sector, because that is where we have all the specialists in particular when it comes to people who have severe mental illness, when it comes to looking after them. And then, of course, also our multilateral organizations and our civil society organizations. So this is how we looked at who are the stakeholders. And then we also went back to look at what are the WHO recommendations on community mental health. And as you can see, mental health has been recognized as part of the SDG agenda. And then there is an optimal mix of services that can be adopted by the member countries to provide better services. And this model in particular highlights the role of informal community care. So as you look at this pyramid here, self-care, and then self-care is the base, like everyone, it's something that everyone can do. And over that, we have informal community care. So besides our, the precious resources who are formal mental health care workers, psychiatrists, psychologists, psychiatric nurses, and the entire community that is there, that's something that's a precious and scarce resource. And of course, there is a need to build up on that as well. But since that requires a building up there, takes a lot of time and effort, and we really needed to do something to bridge this gap. So we looked at this for providing guidance, and this says that informal community care is something that is very important. So when COVID had started last year itself, so there was a call from the highest office for civil servants to come out of the silos, get together, and work for the overall benefit of community. So therefore, we had to have this voluntary initiative of civil servants from all India services and Central Group A civil services. And it is called Karuna. And this is anchored in the LBS NAA Mussoorie. And one of the founder members and leaders of the group is my senior colleague, Archana Verma ma'am, whom Dr. Shekhar just mentioned. And it's, ma'am, we're missing you here. I wish she was here because it was under her dynamic leadership that a lot of work by this, not just for mental health, but overall work in the community in terms of different things, like even running a hunger helpline. All of that has been done by Karuna. So now during the second wave this year, sometime in May, we picked up the area of mental health because there was really this need, the felt need to take up this area for work. And several rounds of discussions were held with mentors from NIMHANS, Dr. Shekhar being here, and Safdarjung Hospital, Delhi, CIP Ranchi, AIMS Delhi, AIMS Gorakhpur, academicians were experts on law and disaster management, and Dr. Balaji Singh Chauhan is also here. So after all this deliberation, and we looked at several models and whether it should be mental health first aid or psychosocial first aid or psychosocial support. So a lot of back and forth discussions happened around that. And we've settled on using the term psychosocial support because at this time and in this limited capacity and capability, this is all that we were looking at. And then 9 states came on board. We looked at a kind of pilot program, which we thought we would roll out state by state. So Andhra Pradesh, Assam, Chhattisgarh, Gujarat, Jharkhand, Karnataka, Nagaland, Punjab, Rajasthan, and Tamil Nadu. So these 9 states came forward, and they also contributed to the preparation of the basic strategy paper and the pilot project. So basically, the community mental health architecture that we looked at was something like this. At the core of this particular model or architecture is the mental health volunteer. Now, the mental health volunteer, I'll come in the next slide, I'll come a little more to the details of what they're expected to do. But basically, these mental health volunteers would be provided training by training institutions. And I think we've already discussed a lot of ground on training of trainers, etc., has been already covered by a lot of previous speakers. So that was the idea here. And then in turn, wherever they found cases which required further intervention or intervention at a specialized or mental health care level, a formal sector, they would refer them to these referral institutions, which would be at the discretion of states. And it could be an institution managed by the central government or the state government in the state, or maybe in a neighboring state or somewhere in the region where it's physical access is easy. And then, of course, a large role had to be played. All of this would be housed in the state mental health department, or if there is a mental health society, somewhere one organ or organization of the state mental health, state health department, which would house this entire structure. So the volunteers, what are they going to do? They were to be chosen by a process of selection, like some basic kind of educational background or something would have to be there. That was a prerequisite. They would then receive basic orientation or training in the PFA model, that's the psychological first aid module. And for this, after looking at the various modules and after having discussions with the mentors, we had settled on the ICMR PSA model, which was basically look, listen, and link. And then this entire orientation and training would also give them a ready reckoner, which they could go back to time and time again whenever they had to recheck their process. So after that, they would provide psychosocial support in the community. And this would involve the following steps: information, giving information to people about what is it that mental health comprises, or mental disorders, or if someone is going through something. Then also screen people. They would have a small short questionnaire which they could administer themselves and screen people for whether they were just in distress or they had actually progressed to the disorder stage. And also provide some basic counseling. I don't know if counseling is the right word you use there, but for lack of a better word, like if someone was just distressed and just needed to be comforted or supported. So something like that. And then, of course, after these steps, if there was any need, they could identify certain people who needed to be referred to the formal mental health care system. This is what they were supposed to do. So for these services and activities, we also envisaged helpline, which would be run at the state level, which could be used by anyone for accessing these services. This was both a pull and push model, like there would be a helpline, but also the volunteers would go down to the community level. So it was both ways. Then there would be a dashboard for monitoring all the work that was going on, how much of training has happened, how much of counseling or support or screening, etc. So we envisaged that. And then we needed an IT architecture to support this entire thing. So this was the basic model that Karuna had come up with. And then as on date, like Karnataka launched its training of trainers. Again, Dr. Shekhar has been a pioneer there. This was in July, and they trained volunteers in association with NIMHANS. Rajasthan and Punjab have also trained some field level functionaries for taking mental health to the field. So again, I'm just quoting two studies here. These studies, let me just caution, are, this is what it is. It's not, the figures are not, cannot exactly establish a cause. Like there's no causality which can definitely be said, but there is a study which was published in Lancet in October 2021, which does say that globally cases of major depressive disorder and anxiety disorder have both gone up. And the NCRB data on suicides in India, that was also recently published. So there also we see an increase in the number of suicides. But again, as I said, caution, we cannot really say anything about the causality, whether it is actually only COVID, but still figures worth looking at. So with that, I come to the end of my presentation. And at the same time, Doctor, if I may just take a couple of minutes. So one thing is that from a policy perspective, yes, we are trying to, because this was a voluntary effort. So ultimately, we all have our day jobs to go back to. And we're looking at institutional support now for taking this forward. And also, since we've said so much, so from my own experience, because I also lost my father to the second wave of COVID in April. And because and my mother was ill, my sister was very ill. So we were also one of those families which went through everything that we've read about. And I knew my symptoms and I had severe anxiety. In fact, for 3 months, every day, I would have anxiety attacks. And there was one of the meetings that we had a lot of deliberations on the Karuna model. So just before the meeting, I had a severe, I wouldn't even say anxiety, I think it was a full-blown panic attack. And I don't know how I sat through the meeting that we did. But then in my case, because I had previous experience of lived experience of depression and anxiety, I knew my symptoms and I reached out to my psychiatrist, I reached out to my psychotherapist, I got help in time. And my aim was to prevent myself from slipping into depression. Of course, there was grief. So hopefully, I think it's been okay. I have managed that. But not everyone is fortunate or unfortunate because I had previous lived experience. So people may not recognize, even educated people may not recognize the symptoms that we have. And that's why it's really, really important to take the mental health care services to the community, because there may not be many people who may even recognize the signs and symptoms and come up and seek help. And I think towards that end, we all are working here and we are talking here today. Thank you very much. Thank you.
Thanks. There has been quite a large amount of a standard deviation, what we had gone about, almost about 30 minutes of the thing. So let me finish it in terms of only one slide as the chairperson's remark. And before that, we do value what Karna community has brought us in terms of where there is no psychiatrist, there needs to be a sort of a mental health volunteer who takes over. Last slide, wait. Last, sabka last. Where there's no psychiatrist, let us have, like what Balaji said, an Apta Mitra or a mental health volunteer to have the availability, accessibility, and affordability for a type of a psychosocial support or mental health services. And as a part of the chairperson's remark, let us build the community resilience on looking at just not the corona alone, but the larger disaster risk reduction communication systems, and be prepared with the initiatives both by the government with the equal amount of a partnership with the non-governmental and civil society organization. And let us have the knowledge, attitude, and practices related to the disaster preparedness coming in front, and to build a socio-economic wellness along with the physical and mental health, and bring in a community, set in awareness, bring in behavior change, and continuation through collaboration. Let that be the word for our community resilience. Thank you, one and all, for having been present here, and those who had been on virtual. And I do really thank my IT support, which did a wonderful job in terms of coordinating this session. Thanks, one and all.
Thank you, everyone.
Thank you.
Thank you, Dr. Shekhar, and thank you to all the esteemed speakers. And now to quickly present a memento to the esteemed session chair. I'd request Ray to please join us on stage. We have Dr. Ananda Babu. I'll request you both to please join us on stage to do the memento and the certificate presentation.
My name is Janal Badani.
I request Dr. Muzaffar Ahmed to please join us on stage as well. I request the mementos to be brought forward, please. The memento to the session chair. Thank you, Dr. K. Sekar.
Good morning.
We thank Mr. Manish Mohandas. We thank Dr. Hannah Fanny. And we also thank Dr. Nancy Miller, who's also joined us virtually. Meanwhile, Dr. Nimesh Desai also joined us virtually. We'd like to thank Dr. Jayakumar, who's present here. Thank you so much. We thank Ms. Subrata Prakash. I request General Badani to please do us the honors. And our thanks to Mr. Balaji Singh. Once again, we thank our esteemed speakers, the session chair, and all of you who have joined us on stage to present the mementos. Thank you for doing us the honors. And ladies and gentlemen, today is a special day because we have made special arrangements for tea right outside. So let me request you to take a quick 10-minute break only for tea and join us back in time, because we are in for a very exciting session ahead, which is being organized by Defense Research Development Organization. So please do join us back, and we look forward to the deliberations in that session, but only 10 minutes. Thank you.